Picture this. You're standing in the resuscitation bay of the emergency department. It's 2:00 a.m. The air conditioning is humming, but you're sweating because you have a patient in bed 4 who looks just absolutely terrible.
We've all been there.
We have. He's a 45-year-old male, clutching his stomach, writhing in that specific way that tells you this isn't just a bad burrito. He describes the pain as a hot iron boring straight through his epigastrium to his back.
The classic presentation, textbook.
Exactly, the classic. You run the labs, the lipase comes back, and it just catches your breath. It's 900.
Wow.
You check the calcium, and it's surprisingly low. You rush him to the CT scanner, hoping for something simple, something easy, but the report comes back screaming, pancreatic necrosis.
And that's the nightmare scenario.
Yeah.
This is the moment where, the rubber meets the road, all the book learning, it comes down to this one decision.
It is the absolute nightmare scenario. And here's where careers are made or broken, or at least where high-stakes exams are passed or failed, because you have 3 choices staring you in the face, and the clock is ticking.
Right. Do you start broad-spectrum antibiotics immediately? Do you call the surgeon to open him up right now? Or do you do nothing? Do you wait?
And the tension you're feeling right now,
Yeah.
that sort of desire to do something, that is exactly what the examiners want you to feel.
Ah, so it's a trap.
It's the ultimate trap, because getting this wrong isn't just a lost mark on a test. In the real world, reacting impulsively here is a major, major clinical error.
So today, we're not just talking about a disease. We're walking into the minefield of acute pancreatitis. But we are doing it with a very specific mission. This is a masterclass. We are looking at this through the lens of high-stakes medical exams, your NEAT PG, INEC, USMLE, MRCS. Exactly. We aren't just going to recite the textbook definition. That's not helpful. We need to navigate the traps. The examiners know where you're going to slip up. They know you see necrosis, and your hand immediately reaches for the antibiotic order.
Or dead tissue makes you think surgery.
Of course. And they're waiting. They're waiting for you to make that mistake.
So, consider this your survival guide. We are going to decode the logic behind the questions, the radiology traps, the biochemistry pitfalls, the scoring systems that everyone, crams and then forgets, and the controversial surgical timing.
It's all about being retention optimized. We want you to understand the why, so you never forget the what. If you understand the physiology, the why of it all, you don't really need to memorize the list. It just makes sense.
Let's unpack this beast then.
Yeah.
We need to start at the very beginning with the biology. When we say acute pancreatitis, what is actually happening inside the body? Because, inflammation of the pancreas sounds a bit too polite for what's actually going on.
It's way too polite, to put it mildly. At its core, yes, acute pancreatitis is an acute inflammatory process, but the mechanism is fascinating and, frankly, terrifying. It is essentially autodigestion.
Autodigestion.
The pancreas is eating itself from the inside out.
That's a horrifying image. It's like the stomach digesting itself, but worse.
Much, much worse. Think about what the pancreas does. It is a factory for the most potent digestive enzymes in the human body. You've got proteases to break down meat, lipases to break down fat, amylases for carbs. It's an arsenal.
And normally those are all kept under lock and key.
Very tight lock and key. Usually nature is smart. These enzymes are stored in an inactive form. We call them zymogens, inside these little bubbles called granules. They're packaged safely so they don't hurt the pancreas itself. They're only supposed to wake up when they hit the duodenum.
Right. They need to be activated by enterokinase in the gut. That's the trigger.
That is the one and only intended trigger. But in pancreatitis, you have premature activation. The enzymes wake up while they're still inside the organ. It is like a grenade going off inside the munitions factory.
And there's a specific villain in this story, right? One enzyme that kicks it all off.
There is. And if you remember one name from this section, this is it. Trypsin. That's the name you need to circle, underline, and highlight. Trypsinogen gets converted to trypsin prematurely inside the pancreas.
So it's the first domino.
It's the first and the biggest domino. Trypsin is the general. Once trypsin gets activated, it triggers a cascade. It goes around activating all the other zymogens, elastase, phospholipase, kallikrein. It wakes up the whole army.
So trypsin is the match that lights the fire.
It's the match. And once that fire starts, elastase starts eating the blood vessel walls. That's what causes the hemorrhage. Phospholipase A2 breaks down cell membranes. That's what causes the necrosis. It's a full-blown biochemical riot.
A riot inside the pancreas. Okay, so trypsin activation is the central event. Now, let's talk about who lights the match, the etiology. If I'm sitting in an exam hall and I get a question about the cause of pancreatitis, what's the statistical favorite? What's the #1 cause?
Okay, so if they ask for the most common cause overall, In the general population, the answer is gallstones.
Yeah.
Period. Full stop. Depending on the study you read, it's anywhere from 40 to even 70% of all cases.
And the mechanism there is purely mechanical, isn't it? It's a plumbing problem.
It is purely a plumbing problem. A stone slips out of the gallbladder, travels down the common bile duct, and gets stuck at the ampulla of Vater, which is the shared exit for the bile and pancreatic ducts.
So it blocks everything up.
It blocks the pancreatic duct. Pressure builds up behind the blockage.
Like putting your thumb over a garden hose.
Exactly like that.
Yeah.
And that back pressure damages the acinar cells, the factory cells, and boom, trypsin activation. It's a surprisingly simple mechanical problem with devastating chemical consequences.
Okay, so gallstones are number one. But we know the examiners love to tweak the demographics. They change the patient profile. What if the patient in the question isn't a 40-year-old female, but a 25-year-old male?
Then the demographic shifts the probability entirely. For a young male, specifically, the most common cause is alcohol.
Alcohol. And we're not talking about a had one beer too many situation, are we?
Rarely. Very rarely. Usually this is chronic, heavy usage. We are talking years of heavy drinking, and then a binge, a particularly heavy bout of drinking, is what triggers the acute event.
So it's an acute on chronic picture.
In many cases, yes. Alcohol has a couple of nasty effects. It's toxic to the acinar cells directly, and it also causes the sphincter of Oddi to spasm, which, again, increases that back pressure in the ducts.
Right. So context is everything. Gallstones overall, alcohol for the young guys. Now, here's one where I know people get tripped up, hypertriglyceridemia. We know high fats can cause it. But is there a magic number, a specific threshold?
There is, and the examiners absolutely love this number because it separates the generalists from the experts. You might see a patient with triglycerides of 500 or 600 in a clinic. That's high, yes. That's bad for your heart.
But it won't cause pancreatitis.
It rarely causes acute pancreatitis, so if the vignette says 600, you shouldn't just jump to that as the cause. You should keep looking.
Okay, so what's the number?
The specific threshold for significant risk is triglycerides greater than 1,000 milligrams per deciliter.
1,000.
1,000. And usually, when we see this clinically, it's in the thousands, 2,000, 3,000. The phlebotomist will tell you the blood literally looks like strawberry milkshake. It's that fatty.
That's a massive number. And why does the fat cause the inflammation? Is it just clogging the ducts like a gallstone?
That's a common misconception. It's not a mechanical blockage. It's chemical. The pancreatic lipase, which is normally there, starts breaking down those massive amounts of triglycerides into free fatty acids right there in the bloodstream.
And those are toxic.
Highly toxic. When you have that much fat, you get a massive release of free fatty acids locally in the pancreas. These acids damage the capillary endothelium and the acinar cells directly. It's pure chemical warfare.
Fascinating. Now let's talk about iatrogenic causes. Sometimes we, the doctors, are the ones causing the problem.
Unfortunately, yes. And the big one here, the one that always comes up, is ERCP, endoscopic retrograde cholangiopancreatography.
Which, ironically, is a procedure we use to fix bile duct problems, like removing stones.
Exactly. But it's an invasive procedure. It involves cannulating the duct, poking around at a very sensitive area, and injecting contrast dye.
And the pancreas hates being poked.
It hates it. Pancreatitis is the single most common complication of the ERCP procedure. It happens in about 5 to 10% of cases, but it can be up to 30% in certain high-risk patients.
So if you have a patient who just had a procedure to fix their bile ducts and suddenly, 12 hours later, they have severe epigastric pain.
You put 2 and 2 together, it's post-ERCP pancreatitis. And here's a quick preventative pearl that examiners like to ask about. We often give rectal NSAIDs, like indomethacin, or place a temporary pancreatic stent during the procedure to lower that risk.
Rectal NSAIDs preventing pancreatitis. I remember first hearing that and thinking it sounded like voodoo, but the data is there, isn't it?
Oh, it's solid data. It inhibits the inflammatory cascade before it can even get started. It's a very effective and simple intervention.
Okay, those are the big hitters. Gallstones, alcohol, lipids, ERCP. But we are here for a masterclass. We want the trivia traps, the obscure stuff that shows up on exams just to test if you have photographic memory. Let's talk drugs.
Ah, the drug list. This is often where students lose points because they just memorize a list without any context.
Yeah.
But there are 4 or 5 big ones you see repeatedly. Azathioprine, valproate, thiazides, and tetracycline. Let's break those down. Azathioprine, valproate, thiazides, tetracycline. Any way to organize that mentally so it's not just a random list.
Context is your memory aid. Absolutely. Don't just learn the drug name, learn the patient. Azathioprine, or its metabolite 6-MP, is used for inflammatory bowel disease or other autoimmune conditions.
So if the vignette describes a patient with Crohn's disease who develops pancreatitis,
You immediately look at their med list for azathioprine. That's the link.
that makes sense. And Valproate.
Valproic acid is for seizures or bipolar disorder. So a young patient with epilepsy presenting with abdominal pain, don't just assume it's an abdominal migraine or something strange. Check if they're on Valproate.
Good point. And thiazides.
That's your classic elderly hypertensive patient. Hydrochlorothiazide is ubiquitous, a rare side effect for sure, but because so many people are on it, you see it, and it's very testable. And there's one more cause that I think is specific to certain regions, specifically India or tropical regions, right? It's a bit of an odd one.
Yes, the scorpion sting. Specifically, the red scorpion Mesobuthus tamulus in India, or Titius trinitatis in Trinidad. It's a classic exam favorite, especially for international exams.
A scorpion sting? How on earth does venom cause pancreatitis? It seems so unrelated.
The venom is a potent neurotoxin. It causes a massive, uncontrolled release of acetylcholine from the nerve endings throughout the body.
Okay.
And that acetylcholine overstimulates the pancreas to secrete a huge volume of enzymes while simultaneously causing the center of Oddi to spasm shut.
So it's the perfect storm.
The absolute perfect storm. High secretion against a closed door. It's a recipe for disaster.
High secretion against a closed door. That's a great way to visualize it. Okay, so we know what causes it. Now let's move to section 2. Diagnosis. The patient is in front of you. How do we officially stamp pancreatitis on their chart?
We use the revised Atlanta classification criteria. And the rule is simple. It's the 2 of 3 rule. You need 2 out of the following 3 criteria to make the diagnosis.
Okay, let's walk through them. Number 1.
Number 1, typical abdominal pain. That's the epigastric pain we talked about. Acute onset, often severe, and frequently radiating to the back.
Number 2.
Number 2, biochemical evidence. This is the lab test. It means serum amylase, or preferably lipase, greater or equal to 3 times the upper limit of normal.
Pause there. 3 times. That's a critical detail, isn't it? So if the upper limit of normal is 100 and the patient's level is 200?
It doesn't count for the criteria. It has to be a significant elevation. So 300 or more in your example. Slightly elevated enzymes can happen in a dozen other conditions. Gastritis, renal failure, you name it. The 3 times rule gives you specificity.
Got it. And number 3?
Number 3 is characteristic findings on imaging. So that's usually a contrast-enhanced CT, an MRI, or sometimes just an ultrasound showing an inflamed pancreas.
So, 2 of 3. That means if I have a guy with the classic back pain and a lipase of 1,000, do I actually need the CT scan to diagnose him?
Technically, no. You have 2 out of 3. You have the pain and the labs. You've made the diagnosis. You do not need the scan just to say he has pancreatitis. In fact, as we'll discuss, scanning him early might be a complete waste of resources if he's otherwise stable.
That's a crucial point. We love our donuts of truth, the CT scanner, but clinical judgment comes first. Now let's get into the enzyme wars. Amylase versus lipase. In the old days, we talked about amylase a lot, but now?
No, lipase is the king. It's the undisputed champion. If you have to choose one, if you only have one test you can order, you choose lipase every single time.
Why is lipase so much better?
2 main reasons, and you need to know both: specificity and duration. Let's tackle specificity first. Amylase is, for lack of a better word, messy. It's not just in the pancreas. It's in the salivary glands, the fallopian tubes, the gut lining. It's all over the place.
So if I have a patient with mumps?
Their amylase will be high because their salivary glands are inflamed. If someone has a perforated bowel, amylase leaks out. If a woman has a ruptured ectopic pregnancy, amylase can be high from the fallopian tubes.
Wait, ectopic pregnancy? That is a massive, massive trap.
It is a huge trap. If you have a female patient of childbearing age with abdominal pain and a high amylase, do not get tunnel vision on the pancreas. You must rule out an ectopic pregnancy. Lipase, on the other hand, is much, much more specific to pancreatic tissue.
Okay, so lipase wins on specificity. What about duration, the timeline?
This is the timeline trap. Amylase rises very early, within 2 to 12 hours of the insult. But it has a very short half-life, maybe 10 hours or so. It gets cleared by the kidneys rapidly, so it can return to normal within just 3 to 5 days.
And patients don't always come to the hospital on day 1.
Exactly. A lot of people try to tough it out at home for a couple of days. If they come in on day 4 or day 5, their amylase might be completely normal. You could get a false negative.
And lipase?
Lipase rises early too, but it stays elevated for much longer, usually 8 to 14 days. It's the marathon runner of the two.
So amylase is the sprinter, lipase is the marathon runner. If the patient presents late, you have to trust the lipase.
Absolutely. Or, interestingly, you could trust the urine. Urinary amylase actually stays elevated longer than serum amylase, but to be honest, nobody really orders that anymore. Just get the lipase. It's simpler and better.
Now, are there any times when both enzymes are normal, but the patient still has pancreatitis? Can that happen?
Yes, it's rare, but it definitely happens. And it happens in two key scenarios. One is the very late presentation we just discussed, where everything is normalized. The other, and this is a bit more subtle, is in acute on chronic pancreatitis.
Explain that. What does that mean?
If a patient has chronic pancreatitis, their pancreas is burned out, fibrotic, shriveled from years of damage, they might not have enough healthy, functioning acinar cells left to produce a massive enzyme spike.
So their factory is just broken.
The factory is mostly shut down. They can have a significant acute flare-up, a genuine episode of acute pancreatitis, but with normal or only slightly elevated labs. That's a very tricky diagnosis that often relies on imaging.
That is definitely a masterclass level detail. Now, moving from the labs to the physical exam. We learn these signs in medical school, and they sound so dramatic. Cullen sign and Gray-Turner sign.
The rare but tested signs, we love them because they have names, they're eponyms. Cullen sign is ecchymosis, which is just a fancy word for bruising around the umbilicus.
I remember the mnemonic C for central or C for circle around the belly button.
That's a good one. And Gray-Turner sign is bruising on the flanks. The mnemonic there is you have to turn the patient over to see their flanks.
They sound cool, but what do they actually mean physiologically?
They mean blood. Specifically, they mean retroperitoneal hemorrhage. The pancreas is a retroperitoneal organ. If it becomes severely necrotic and starts bleeding, that blood tracks along the fascial planes of the abdomen.
And it just finds the path of least resistance to the skin.
Exactly. It can track along the falciform ligament to the umbilicus, causing the Cullen sign, or along the perirenal space to the flank, causing the Gray-Turner sign.
And the timeline. Do we see this in the ER on hour 1?
Absolutely not. It takes a good 24 to 48 hours for that blood to track all the way to the skin. So these are late signs, and more importantly, they are signs of very severe disease. If you see Cullen sign, the mortality risk is extremely high.
So it's not a handy early screening tool.
Not at all. It's a sign that the ship is already taking on a lot of water. It's a prognostic sign, not a diagnostic one.
So if the question asks for an early physical sign of pancreatitis, do not pick Cullen.
Correct. You pick epigastric tenderness. That's the early sign.
Speaking of prognosis, let's slide into section 3. We're looking at the lab sheet again. In severe pancreatitis, the labs go completely haywire, and the examiners want you to explain why. Let's start with calcium. In our cold open with our patient in bed 4, his calcium was low. Why does that happen?
This brings us back to high school chemistry. It's a process called saponification.
Saponification. Making soap.
Literally making soap. Remember how we said the enzymes, particularly lipase, are digesting the fat around the pancreas? That's fat necrosis.
Yes.
Well, when triglycerides in the fat cells are broken down, they release free fatty acids. These acids are negatively charged. Calcium in the bloodstream is positively charged. They bind together.
Opposites attract.
Exactly.
Yeah.
And they form insoluble calcium soaps, the white chalky deposits that surgeons sometimes see scattered throughout the belly during surgery. That's soap.
So the body is using up all its free calcium to make this soap.
Precisely. The calcium is being pulled out of the bloodstream and deposited in the retroperitoneum, hence hypocalcemia.
So the degree of hypocalcemia directly correlates with the amount of fat necrosis.
That's the key takeaway. Lower calcium equals more necrosis, which equals a worse prognosis. It's a very reliable marker of severity.
What about glucose? Why does that go up, hyperglycemia?
Two main reasons. The first is just the general stress response. Any critical illness causes cortisol and catecholamines to rise, which drives up blood sugar. But there's a pancreas-specific reason, too.
The islet cells.
The islet cells. The inflammation can injure the islets of Langerhans, specifically the beta cells that make insulin. If you knock out the insulin factory or even just stun it, blood sugar is going to spike.
Okay, now here's one that seems paradoxical, at least at first glance. Hematocrit. Usually in a sick patient, we worry about bleeding and the hematocrit dropping, but here, an elevation is a bad sign.
Yes, and this is one of the most important concepts to grasp in early management. An elevated hematocrit early on, say, an HCT over 44% or 50% on admission suggests hemoconcentration.
Which means?
It means the plasma, the water part of the blood, is leaking out of the blood vessels. This is third spacing. The systemic inflammation makes all the capillaries leaky. Fluid pours out into the tissues, into the retroperitoneum, leaving the red blood cells behind, concentrated in the vessels.
So if the hematocrit is high, the patient is effectively profoundly dehydrated from a volume standpoint.
profoundly dehydrated. Their intravascular volume is tanking. This leads to poor organ perfusion, which worsens the pancreatic necrosis. It's a vicious cycle. If you see a high hematocrit on admission, that patient is in danger.
And if it doesn't come down with fluids?
That is a very, very bad prognostic sign.
Yeah.
We want to see that number come down as we rehydrate them.
Yeah.
It tells us we're filling the tank back up.
So we want to dilute them back to normal.
Exactly. That's a great way to put it.
What about BUN, blood urea nitrogen?
It's a similar concept. BUN rises with dehydration, what we call pre-renal azotemia. But a rising BUN, specifically a BUN that continues to rise despite what you think is adequate fluid resuscitation, is arguably the single most reliable predictor of mortality in acute pancreatitis.
More than any other lab?
Many would argue yes. If the BUN keeps going up over the first 24 hours, your patient is at very high risk of dying.
And CRP, C-reactive protein.
CRP is useful, but it's a lagging indicator. It's an acute phase reactant, so the liver has to get the signal and then churn it out. It takes time. It usually peaks around 48 to 72 hours.
Is there a number to remember?
Yes. The magic number is 150. A CRP greater than 150 milligrams per liter at 48 hours is a strong predictor of severe pancreatitis and necrosis. But on admission, it might be totally normal, so you can't use it to triage patients in the first few hours.
Okay, so we've assessed the damage with labs. Now we need to label it. The classification. We use the Revised Atlanta classification. How do they break it down? What are the categories?
They moved away from some of the older, vaguer terms and focused on one thing that really matters: organ failure. The classification has 3 tiers: mild, moderately severe, and severe.
Let's distinguish them. Mild pancreatitis.
Mild is the most common, about 80% of all cases. This is what you hope for. There's no organ failure. There are no local complications like necrosis or significant fluid collections. They get admitted, get IV fluids, pain meds, and they usually go home in 3 to 5 days.
Simple enough. What about moderately severe?
This is the middle ground. This is where things get more complicated.
Yeah.
It's defined as having transient organ failure, meaning organ failure that resolves within 48 hours. Or it could be defined as having local complications, like a fluid collection or necrosis, but without any persistent organ failure.
So the organ failure is the key, but it gets better quickly.
Exactly. The kidneys might take a hit or their oxygen might dip, but with good support, they bounce back in a day or 2.
And severe.
Severe is the killer. This is the one we fear. It's defined by one thing: persistent organ failure. Organ failure that lasts longer than 48 hours.
And just to be super precise for an exam, how do they define organ failure? It's not just the doctor feeling like the patient looks bad, is it?
No, we need objective data.
Yeah.
I use something called the Modified Marshall Score. It's a simple score that looks at 3 organ systems: respiratory, using the PaO2-FiO2 ratio; renal, using the creatinine level; and cardiovascular, using the systolic blood pressure.
And what's the threshold?
A score of 2 or more in any of those 3 systems equals organ failure for that system.
Got it. So if the creatinine stays high for 3 straight days, that's persistent renal failure, and that automatically makes it severe pancreatitis.
Correct. No matter what the CT looks like, the physiology trumps the anatomy.
Now, speaking of scores, this is where students start sweating the numbers game. Section 4. We have to talk about the Ranson criteria.
The classic Ranson criteria. It was developed in the 1970s. It's ancient by medical standards. It's cumbersome. It has way too many variables. And honestly, we rarely calculate it at the bedside anymore because it takes a full 48 hours to complete. But the examiners, they're nostalgic. They absolutely love it. So you have to know it.
So we have to learn it. And the crucial distinction here, the main trap, is that Ranson has 2 distinct parts.
Right. There are the criteria on admission at hour 0, and then there's a completely different set of criteria at 48 hours. You cannot mix them up.
Let's run through the admission criteria rapidly. There are 5 of them.
We use the mnemonic GA law. GALAWG is for glucose 200 milligVO. A is for age 55 years. L is for LDH 350 IUL. A is for AST 250 IUL. W is for WOBC, the white blood cell count, 16,000.
And these all reflect the initial inflammatory burst, right? The stress hyperglycemia, the liver enzymes from inflammation, the high white count.
Exactly. It's a snapshot of the initial systemic hit. And notice something important. Amylase and lipase are not in the Ranson criteria.
That's a classic trick question.
A very common one. They'll ask which of the following is in Ranson's criteria, and they'll list lipase. It's not there. The diagnostic markers are not prognostic markers in this score.
Good catch. Now, 48 hours later, we reevaluate. We've been pouring in fluids. The patient is in the unit. What are we looking for now?
Now we're looking for the aftermath. This is the evidence of how much damage was done and how much fluid had been lost. The mnemonic is CHOBBS. Okay,
CHOBBS.
break it down. C is for calcium, 8 mg/dL, from that saponification we discussed. H is for hematocrit fall, 10 percentage points. O is for oxygen, a PaO2 60 mmHg, which signals lung injury. B is for BUN rise, 5 mg/dL, despite fluids. Another B is for base deficit, 4 MOEQL, showing metabolic acidosis. And S is for sequestration of fluid, estimated to be 6 liters.
Let's unpack the why for a couple of these, because that helps with memory. Why the hematocrit fall after 48 hours?
Two potential reasons. The good reason is that you successfully rehydrated them and diluted their blood. The bad reason is that they've had a significant hemorrhage into the retroperitoneum.
And the PaO2 60, why is the oxygen dropping so badly?
Because the systemic inflammation damages the lungs. Those pancreatic enzymes, specifically phospholipase A2, circulate to the lungs and destroy surfactant, which is the substance that keeps the air sacs open. This leads to ARDS, acute respiratory distress syndrome.
The lungs get stiff and wet.
Exactly. And that sequestration of fluid, more than 6 liters, that is a massive amount of fluid hiding inside the body. It's unbelievable. That's all the third spacing is edema in the gut wall, fluid in the peritoneum. It's fluid that is inside the body but is completely useless to the circulation.
Okay, Ranson is the old guard. What about the modern favorite? The one that's actually practical, the BIASAP score.
BISAP is so much friendlier. It stands for Bedside Index for Severity in Acute Pancreatitis. And the beauty is you can calculate it right there in the ER within minutes of seeing the patient. All the data is readily available.
Break it down for us. BISA.
B is for BUN, 25 mg/dL. There's BUN again, showing its importance. I is for impaired mental status, so any confusion or Glasgow Coma scale less than 15. S is for SIRS criteria, so meeting 2 or more criteria for systemic inflammatory response syndrome. A is for age 60. And P is for pleural effusion on imaging, like a chest x-ray.
That is so much easier to remember and calculate. And what's the danger score? What number should make us worry?
A score of 0 to 2 is considered low risk, but a score greater than or equal to 3 indicates a high risk of mortality, somewhere in the range of 15 to 20%. If your patient has a BISAP of 4, they need an ICU bed immediately, no question.
Let's apply this to our cold open patient. He had necrosis, lipase 900. Let's say he's 65, he's a bit confused, and his BUN on arrival is 30.
Okay, so age 60, that's 1 point. BUN 25, that's another point. Confused, impaired mental status, that's a third point. He's already a BISAP 3 right out of the gate.
High risk.
Very high risky. He needs aggressive care from minute 1.
Excellent. So we've diagnosed it, classified it, and scored it. Now we need to see it. Section 5, imaging strategy. And here lies perhaps the biggest trap in the entire topic.
The timing trap, without a doubt.
The patient comes in, severe pain, enzymes are sky high, we're worried, we want to know how bad the necrosis is. Do we send them for a contrast CT scan immediately?
No, and I will say it again for everyone listening, do not do an early CT scan to look for necrosis.
Why not? I mean, more information is better, right? Why are we waiting? What's the harm?
The harm is that you'll be falsely reassured. It's because of the physiology of cell death. Necrosis takes time to declare itself on a scan. If you scan at 6 hours or 12 hours, the pancreas might just look a little swollen and edematous.
So it looks better than it actually is.
Much better. The contrast might still perfuse tissues that are in the process of dying but aren't fully dead yet. You will completely underestimate the severity of the disease.
It's like looking at a bruise 5 minutes after you hit your leg. It hasn't turned purple yet, but the damage is done.
That is a perfect analogy. You need to wait for the tissue to fully die and stop taking up the contrast dye. That's what necrosis is on a CT, an area that doesn't light up.
So what's the magic number? How long do we wait?
The 72-hour rule. A contrast-enhanced CT, a CECT, is best performed after 72 hours, so 3 days, from the initial onset of symptoms. That is when the demarcation between healthy tissue, which will light up with contrast, and necrotic tissue, which stays dark, is clearest.
So if the vignette says, patient presents at hour 6, vitals are stable, diagnosis is clear from enzymes, what is the next best step? And one of the options is CT abdomen.
You do not click it. You run away from that answer. You click aggressive fluid resuscitation and pain control.
But wait, are there any exceptions? When would I scan a patient early?
There are a couple. The main one is if the diagnosis is in doubt. Let's say the enzymes are only borderline, and you're worried about a perforated peptic ulcer or bowel ischemia, and you need to rule those out.
So for differential diagnosis?
Exactly. Or if the patient is crashing and you suspect a massive hemorrhage or some other catastrophe, but purely for staging pancreatitis severity. Wait 72 hours.
Okay. What if we just want to know why they have pancreatitis? We suspect stones, but we're not sure.
Then you use ultrasound, and abdominal ultrasound is the gold standard for detecting gallbladder stones. It's better than CT for that specific question. CT actually misses some radiolucent gallstones.
So the algorithm is ultrasound on admission for etiology, CT after 72 hours for complications and severity.
You've got it. That's the perfect summary.
And what if the patient has renal failure and can't take the contrast dye for the CT?
Then MRI is a very useful alternative. It doesn't require iodinated contrast, though it uses gadolinium, and it's excellent for visualizing the ducts and any fluid collections.
Okay, well, let's move to the part where we actually treat the patient. Section 6, management algorithms. We have three big pillars here: fluid, food, and pharm. Let's start with fluid.
Fluid resuscitation is the cornerstone. It is the single most important intervention. You can win or lose the game in the first 24 hours based on how you manage fluids. The goal is to counteract that massive third spacing and hemoconcentration we talked about.
Now, for a long time, the debate was normal saline versus lactated ringers. What's the verdict from the latest evidence?
Verdict heavily favors lactated ringers, or LR.
Why? I mean, saline is cheaper and it's everywhere. What's wrong with saline?
The problem with normal saline, which is 0.9% sodium chloride, is the chloride. It has a lot of chloride. If you pump in 4 or 5 liters of it into a sick patient, you cause a hypochloremic metabolic acidosis.
And acidosis is bad.
Acidosis is very bad for the pancreas. It's been shown in studies that a low pH can actually promote the activation of trypsinogen, so you're essentially adding fuel to the fire.
And ringers avoids that.
It does. Lactated ringers has a pH that's much closer to physiological neutral, and the lactate in it actually acts as a buffer against acidosis. Multiple clinical trials, like the waterfall studies and others, have shown that using LR reduces the incidence of SIRS and systemic inflammation compared to saline.
Is there any time you would not use ringers? An exception?
Yes, there's one rare but important exception. If the cause of the pancreatitis is hypercalcemia, so an extremely high calcium level, you should not use ringers.
Because it has calcium in it.
Because it has a small amount of calcium in it. In that one specific rare case, you should use normal saline. But for everything else, gallstones, alcohol, lipids, you use ringers.
And we're not just hanging a bag and walking away. We need targets. We need goals. What are we aiming for?
We practice goal-directed therapy. We want a urine output greater than 0.5 millioil per kilogram per hour. We want the mean arterial pressure, the MAP, to be above 65. But the best markers to follow: watch the hematocrit and the BUN.
And we want to see them dropping.
You want to see them dropping. If the BUN keeps rising over the first 24 hours, you are behind on fluids. Simple as that.
And what's the risk of overdoing it?
That's the nuance. You have to be careful not to drown them. Fluid overload is also dangerous. It can cause pulmonary edema and abdominal compartment syndrome. So the key is aggressive resuscitation early, in the first 12-24 hours, and then you taper back and reassess constantly once the goals are met.
Pillar number 2, nutrition. This has been a massive paradigm shift in the last decade or so.
Huge. It's a complete 180. When I was in training, the absolute rule was pancreatic rest. You keep the patient MPO, nothing by mouth. Don't even let them smell food. Don't let them look at food.
And the logic was, if you eat, you stimulate the pancreas to make more enzymes, which just worsens the autodigestion.
It sounds perfectly logical, doesn't it? But it's wrong.
Why is it wrong?
Because we forgot about the gut. The intestines are a barrier. They keep billions of bacteria from entering the bloodstream. And that barrier, the gut mucosa, requires nutrients to stay healthy and intact. If you starve the patient for days on end, the mucosal barrier atrophies. It breaks down.
And then the bacteria can cross over into the bloodstream?
Yes. You get bacterial translocation. The bacteria migrate from the gut lumen across the leaky gut wall and into the necrotic pancreas. Now you have infected necrosis, and mortality shoots up from maybe 10% to over 30%.
So feeding the gut actually prevents infection?
Exactly. The mantra is use it or lose it. The modern teaching is early enteral feeding, ideally starting within the first 24 to 48 hours.
And what's the hierarchy? Do we start with a burger and fries?
Maybe not a burger. You start with a low-fat diet. Oral is best if they can tolerate it. If they're not vomiting and don't have a severe ileus. If they can't eat, then we use a feeding tube.
Does it have to be a nasopharyngeal tube, an NJ tube? We used to think we had to bypass the stomach to avoid stimulating the pancreas.
That was the old thinking, but multiple studies have shown that a simple nasogastric tube, an NG tube that ends in the stomach, is just as safe and effective as an NJ tube. So putting a tube in the stomach is fine. The key is just to use the gut.
And TPN, total parenteral nutrition, Feeding through the vein.
TPN is the last resort. We really hate TPN in pancreatitis. It's associated with much higher risks of catheter-related infections and metabolic complications like hyperglycemia. You only use it if the gut completely fails, like in a prolonged severe ileus.
So to summarize, NPO is out, feed them early, and use the gut.
That's the new gospel.
Pillar number 3, pharm, or specifically antibiotics. In our cold open, the patient had necrosis. The resident's first instinct is to give antibiotics.
And that is the classic trap. The rule is very clear. No prophylactic antibiotics in sterile pancreatitis, even if there is severe, widespread necrosis.
Even if 50% of the pancreas is dead on the CT scan.
Even then, necrosis is dead tissue, but it starts out as sterile dead tissue. If you blast the patient with broad-spectrum antibiotics from day one, you kill all the sensitive bacteria in their body, but you select for highly resistant organisms and, even worse, fungi.
So you end up creating a super infection down the line.
Exactly. Fungal pancreatitis is an absolute nightmare to treat. So the rule is, do not give antibiotics unless you have clear proof of infection.
What constitutes proof?
A few things. Clinical deterioration, usually after the first week of illness, so a new fever, a rising white count, crashing blood pressure, or the most definitive sign, seeing gas in the pancreatic collection on a repeat CT scan.
Gas means bugs.
Gas means anaerobic bacteria in there fermenting the dead tissue. That is an absolute indication for antibiotics.
And if we do need them, let's say the necrosis is definitely infected, what's the drug of choice?
You need something that penetrates the pancreas well. The dead tissue has poor blood supply. The carbapenems are the gold standard. So imipenem or meropenem. Fluoroquinolones like ciprofloxacin combined with metronidazole are a reasonable alternative. But for an exam, carbapenems are the go-to answer.
Okay, that brings us naturally to section 7, complications and surgery. The surgeons are downstairs sharpening their scalpels. When do we let them into the room?
We talked about necrotizing pancreatitis. You have this collection of dead tissue. In the first 4 weeks, it's called an acute necrotic collection. It's a messy, unorganized mix of fluid and semi-solid debris.
And we mentioned gas on CT is the telltale sign of infection.
Right. If you see those little gas bubbles, it means bacteria like E. coli or Klebsiella are in there. That is an indication for intervention.
But intervention doesn't necessarily mean open surgery, does it?
Correct. This is another huge paradigm shift. We now follow the step-up approach. This is proven by a landmark Dutch trial called the Panther trial. We used to do a big open operation on everyone. Now we start minimally invasive.
So what's step 1?
Step 1 is just antibiotics for the proven infection. If the patient doesn't improve on antibiotics alone, then you move to step 2, which is drainage. This can be percutaneous drainage, where an interventional radiologist puts a tube through the skin into the collection, or it can be endoscopic drainage, where gastroenterologist goes through the stomach wall.
And if that still fails, if the drains aren't enough?
Then you escalate to step 3, which is a minimally invasive debridement, something like a video-assisted retroperitoneal debridement or VARD. And the absolute last resort, only if all else fails, is the traditional open necrosectomy.
And the timing of all this is critical, isn't it?
The timing is everything. We try to delay any invasive procedure for ideally more than 4 weeks from the start of the illness.
Wait, 4 weeks? That seems like a really long time to leave a bag of infected dead tissue inside someone. Why wait so long?
It's all about the biology of the wall. Over those 4 weeks, the body's inflammatory response forms a thick, fibrous capsule around the necrosis. It becomes what we call walled-off necrosis, or 1.
And why does that wall matter so much to the surgeon or the endoscopist?
It makes the procedure infinitely safer and more effective. If you go in early, before the wall has formed, the pancreas is like a fragile soup or a jelly. You try to scoop out the dead stuff, and you end up damaging healthy tissue, causing massive bleeding. It's a complete mess.
It's not well defined.
Not at all. But if you wait 4 weeks, the dead tissue is neatly contained inside this thick wall. It separates from the healthy tissue. It's distinct. You can go in and scoop it out easily without hurting the viable organ.
One surgeon described it to me as picking a ripe fruit. It just comes away cleanly.
That is the perfect analogy. So the bottom line for exams, early surgery increases mortality. Delayed surgery after 4 weeks improves outcomes.
What about gallstone pancreatitis specifically? The stones are still in the gallbladder. Do we need to fix that now or later?
This is a tale of 2 very different scenarios. Scenario A. The patient has cholangitis. That's an infection of the bile duct, in addition to the pancreatitis. They are septic, jaundiced, they have shaking chills. That's Charcot's triad.
That sounds like a surgical emergency.
It's an endoscopic emergency. That patient needs an urgent ERCP within 24 hours to get that stone out and decompress the infected biliary tree.
Okay, that's scenario A. What about scenario B? No cholangitis? Just the pancreatitis caused by a stone that has probably already passed into the gut.
Then you can wait on the ERCP. You don't need to do one emergently. You focus on supportive care for the pancreatitis. But, and this is a key point that's often tested, you cannot send them home with that gallbladder still in.
Why not? Just let them cool down for a month and bring them back.
No. The P-on-Shio trial showed that if you send them home without taking out the gallbladder, there's a very high risk, something like 20 to 30%, that they will drop another stone and come right back with recurrent pancreatitis within a few weeks.
So you have to fix it before they leave the hospital.
Yes. The standard of care is to perform the cholecystectomy during the same admission, usually once the inflammatory markers have started to settle down. For mild cases, that's often within a week.
Okay. One last complication that frequently appears on exams. Pseudocysts.
A pseudocyst is basically an encapsulated fluid collection that's rich in amylase, surrounded by a fibrous wall. But the key part of the definition is time. It is only defined as a pseudocyst after 4 weeks.
So if I see a simple fluid collection on a CT scan on day 3, it is not a pseudocyst.
Correct. On day 3, it's called an acute peripancreatic fluid collection. It doesn't have a mature wall yet. After 4 weeks, once that wall forms and matures, it officially becomes a pseudocyst.
And do we drain every pseudocyst we see on a scan?
Absolutely not. In fact, most of them resolve spontaneously. We only intervene if they meet specific criteria. There are 4 main indications.
What are they?
1, size greater than 6 centimeters. 2, duration greater than 6 weeks.
All right.
3, if it's symptomatic, so causing pain or pushing on the stomach and causing vomiting. And 4, if it's infected.
The 6-6 rule is a good way to remember the first 2. Greater than 6 centimeters and present for more than 6 weeks.
Exactly. If it's small and asymptomatic, you leave it alone and watch it.
Section 8. Differential diagnosis. We're almost done, but we need to make sure we aren't missing something else that looks just like this. What are the big mimics of pancreatitis?
The lookalikes. And you need to rule out the killers first. Number 1 is a perforated peptic ulcer. It can also cause severe epigastric pain and a high amylase.
How do you tell them apart?
The key is a chest x-ray. In a perforated ulcer, you'll often see free air under the diaphragm. You typically don't see free air in pancreatitis.
What else?
Mesenteric ischemia. The pain is famously out of proportion to the physical exam, and the lactate level will be sky high. Also, an aortic dissection can present with tearing pain radiating to the back. You have to check pulses in both arms and legs.
And the really scary one for elderly patients, the one we can't miss.
Myocardial infarction. An MI, particularly an inferior wall MI, can present primarily with epigastric pain, nausea, and vomiting. It can look exactly like pancreatitis or gastritis.
So the safety check, the one thing you have to do.
Always, always, always check an ECG in an elderly patient who comes in with epigastric pain. Do not assume it's just their stomach or their pancreas. It takes 10 seconds, and it saves lives. Solid advice. Okay, let's bring it all home. Let's go back to our cold open, our friend in bed 4.
Right, the 45-year-old with the boring epigastric pain, lipase 900, low calcium, and that terrible-looking CT showing pancreatic necrosis.
We asked at the beginning, antibiotics, surgery, or wait.
And now we know the answer, don't we? We
Yeah.
do not give antibiotics immediately because there's no gas on the CT and no other evidence of infection yet. And we absolutely do not operate because he's in the early phase, and early surgery would be a disaster.
So the correct plan is?
The correct plan is to wait. It's active waiting. You would admit him to the ICU. You start aggressive fluid resuscitation with lactated ringers, aiming for that good urine output and a falling BUN. You start early enteral feeding, maybe with an NG tube. You monitor for organ failure using the Marshall score or by trending the bias, and you watch and you support and you wait. It feels so counterintuitive to do nothing surgical for such a severe-looking disease, but that is the evidence-based medicine.
It's active patience. That's the art of it. We're supporting the body while it walls off the disaster zone, preparing it for a potential much safer intervention weeks down the line.
Before we sign off, let's do a rapid-fire Pearl session. The absolute must-knows. I'll throw a category, you give me the high-yield exam answer. Ready?
Ready, that's it.
Most common cause overall.
Gallstones.
Best enzyme for diagnosis.
Lipase, more specific, lasts longer.
When to do a CT to assess for necrosis.
After 72 hours, not before.
Role of prophylactic antibiotics.
Do not routinely. only for proven infection.
Fluid of choice for resuscitation.
Lactated ringers.
What's the nutrition plan?
Enteral feeding. Start early, within 24-48 hours.
2 scoring systems you must know?
Ranson, know the admission versus 48-hour criteria, and BISAP for rapid bedside assessment.
When to do surgery for infected necrosis.
Delay for more than 4 weeks if possible, and use a step-up approach.
Fantastic. That's a great summary.
And here's a final provocative thought for you to chew on as we wrap up. We spend so much time in medicine learning how to act, how to cut, how to prescribe, how to intervene. But in severe acute pancreatitis, the data tells us that the hardest and most important skill is restraint. Knowing when not to use the scalpel and when not to write that antibiotic prescription is often what saves the patient's life.
Sometimes doing less truly is doing more. That is it for this deep dive into acute pancreatitis.
Next time we're moving down the timeline, we'll be tackling the smoldering fire of chronic pancreatitis and its deadly cousin, carcinoma of the head of the pancreas.
You won't want to miss that. Until then, keep those synapses firing.
And check your calcium levels.
See you next time.